At the inaugural Abu Dhabi Global Healthcare Week, we have got a packed schedule. There is no breaks for us. We're diving deep into our next panel discussion on liquid biopsy for early cancer detection. So a vital subject area. And to lead us through this, may I please welcome back on stage our expert moderator, Dr. Lawrence Petalidis, who is M42's Head of Global Partnerships. Please give him a big round of applause.
Thank you so much.
Martin Steinberg, the chairman of board A3P Biomedical AB. A big round of applause for Martin. Dr. Azir Attia, who is head of clinical genomics at M42. Dr. Azir, thank you so much for joining us again. We were on stage together at Arab Health. David Malarkey, ClearNote's CEO. Give David a big round of applause. And Dr. Waleed Hassan, the Cleveland Clinic's Abu Dhabi's Department Chair of Urology. Thank you so much, ladies and gentlemen. Over to our experts who, Dr. Lawrence, you'll be able to pronounce the medical terms much better than me, so over to you.
I hope. Thank you so much. Thank you. I'm really delighted to be hosting this session. It's a subject that M42 loves dearly and has placed a lot of emphasis on for over the last few years. My name is Lawrence. I'll be moderating this stellar panel of experts that combine both clinical, scientific, and industry leaders. Our subject today is liquid biopsy. These are blood tests that are very sensitive and can pick up minute amounts of circulating tumor DNA and circulating tumor cells to identify cancers that are in solid cancers in faraway locations in the blood. And there's a lot of activity in this space over the last few years, and we'll be touching upon these technologies today. I wanted to, as an introduction, to mention maybe two personal. I thought that starting with a personal note is a good strategy. So I have two short stories. One goes back to my PhD that was based in brain tumors, and my supervisor at the time, who was leading clinical pathology in a very good university hospital, was saying, Lawrence, all this research that we're doing about prognosis for these brain tumors hasn't changed for the last 40 years. This was 20 years ago. Yesterday night, I checked a couple publications, and I saw that prognosis for these brain tumors hasn't changed for the last 30 years, and this was 2021 publication. So a lot of this prognosis, of course, relates to being able to identify these tumors early. And of course, brain tumors are amongst the worst in this category, but I'm just using this as a use case of the importance of identifying tumors early. The other personal use case for me is my own father-in-law, who did a full screening and was fully okay, and the next year he came back and he had a stage 4 prostate cancer that had metastasized to his bones in 1 year. And again, the importance of early screening. So we're here today to discuss these points, and I would like to start from Dr. Waleed, please. Dr. Waleed, what does this mean for you in your daily clinical practice? How do you see our ability, from a prostate perspective, which is of course central to your specialty, but more broadly perhaps, our ability to detect tumors early, and what does this mean for our clinical practice today?
Well, good afternoon. Thank you for having me. The challenge with cancer diagnosis is multifaceted. And we're challenged at various different stages of the disease, whether it's from early detection to advanced disease, on how we detect and prognosticate. Screening is always a challenge because our goals are to look at a large number of the population and essentially look for a needle in the haystack in a way that is trying to find cancers in people who we should find them in, and not find anything in those where something may never be destined to do anything, because anything we do will lead to complications and interventions and so forth. And that's been really the challenge. So for the past 40 years or so, there's been a blood test, for example, that screens people for prostate cancer, known as PSA, or prostate-specific antigen. That's essentially a type of a marker. It's a protein marker. And although it's been very effective in being able to diagnose prostate cancer early, it has very poor sensitivity and specificity. So we subject significant amount of people in the population to needless tests, needless anxiety, and the diagnoses of quote unquote cancers that may never be destined to do anything. And so those patients, we're really doing more harm than good in those patients. We're also spending a significant amount of money that doesn't need to be spent. And so the idea behind finding signals that may allow us to detect cancers earlier and in the right patients, obviously you can imagine have significant value. So when we're looking at biomarkers, we're looking at signals that can give us the impression on whether someone is at a higher risk than the normal population of having a cancer, and also be quite confident in the negative signals that that patient we can leave alone, as there's a very low chance for having tumor.
Thanks, Dr. Walid. And just as a 30-second additional question to you, from a global perspective, how do you see the rates of tumors in your discipline that are discovered very, very late in clinically unmanageable or poorly manageable stages?
Well, I can tell you that, for example, in the US, 5% of prostate cancers around are diagnosed at a late stage around, and here we tend to see about 20% of our patients come in with more advanced or locally advanced stages. Part of that is to the development of the primary care sector, part of that is to poor education and so forth. And so you can imagine that this is a very young region. There was recent data just in the Lancet predicting an explosion of cancers around the world as societies become more developed, become wealthier, that sort of thing. So we are going to see a wave of not only prostate cancer but other cancers as this part of the world where we have nearly 1 billion people, 30% of, the vast majority of them are under the age of 30. Over the next 20 to 30 years, we're going to see an explosion of, obviously, a demographic explosion of patients at risk for having cancer.
Thanks, Dr. Willie. Thank you. Martin has spent a big part of his professional life trying to address this very problem, and particularly in the from a prostate cancer perspective and out of the Karolinska Institute in Sweden. So I'd love to ask Martin to share his perspective on how these tests work and maybe some use cases of success from other deployments in Sweden or elsewhere. Thank you.
Thank you, Lawrence. So just to follow up with Dr. Walid, I mean, there is a great problem with prostate cancer. We are getting older, and there's a strong correlation between age and prostate cancer. So it's growing. And the early detection, we're talking about the early detection here, the test has been used for 30 years, PSA, is not precise enough. And there are liquid biopsies around, there have been around for some time. The problem with these biopsies is that they are only able to rule out. With men who have an elevated PSA level, they're able to say, you don't have to go on for a biopsy, or you don't have to go on for a MRI. What has been lacking is a liquid biopsy that also can find men early. Because when you find the cancer early, it's nearly always treatable. Even aggressive prostate cancer, if it's found within the prostate, you have nearly 100% survival rate, the 5-year survival rate. So what we have done, we have great success from Europe, from Sweden, and now we hope to implement it here in the region together with the M42. It's a test called Stockholm 3. I'm from Stockholm, so the name Stockholm 3. It's a combination of protein markers, genetic markers, and clinical data. It's algorithm-based, and it tells you something about the risk of having aggressive prostate cancer at biopsy. And the great thing with this test is that we both are able to rule out unnecessary treatments, and we have a higher sensitivity than PSA. So we nearly double the number of men we find early with aggressive prostate cancer.
And Martin, you've published a lot, and you just share with the audience, if you wish, very succinctly, because that clock is already ticking so badly, some of the key statistics or some of the key results that you've seen in your current deployments in terms of health economics or in terms of identifying cancers in more manageable stages. A few percentages or a few improvement points.
So we can, in clinical use, we've seen that we can double the number of men we find with aggressive prostate cancers. We can reduce the number of unnecessary further procedures by 50%. We've done health economics on the European scale, savings between 8 and 30%. So really strong data. Thank you.
Thank you, Martin. I'll pass to Dave, who's also a stakeholder who's devoted many, many years of effort and leadership in this space, but from a pancreatic perspective. So Dave, I'd like to ask you to comment on where you think we are with liquid biopsy for pancreatic cancers particularly, and generally your perspective on this discussion and how you see this technology branching out and becoming more sort of closer to standard of care.
At ClearNote Health, our vision is to cure the world's deadliest cancers. And the technology exists today. So we're focused primarily on the most deadly cancers, focused on early detection in patients at the highest risk for it, where there have been no early detection tools to date. Two examples of that, which are two products we have commercially available in the market today, is early detection of pancreatic cancer, one of the most deadly cancers, typically diagnosed very late stage. And the other is early ovarian cancer. So these are cancers that typically don't show symptoms early on and typically are diagnosed at stage 3 and stage 4 when survival is very poor. And just to give an example for pancreatic cancer, which could be the cancer that has the single greatest extension and saving of life by detecting it early. If you detect pancreatic cancer at stage 1, you have an 80% chance to survive 5 years. If you detect it at stage 4, which is where most of the cases are today, your chance of living 5 years is 3%. It's the most extreme difference anywhere. So that's why we chose to start there. The unmet clinical need is the highest. And we have that test available currently called Avantect. And we feel that we have the ability to replicate this across multiple cancer types. So we'll have a pipeline of new tests coming out, probably one a year, for years and years to come. And what we are focused on, as far as what we're actually measuring, is we're looking at circulating cell-free DNA from tumor cells. So as the tumor cells grow and die, they open and shed their contents in the blood. So we're combining epigenomic and genomic signals from those fragments of DNA by using a standard blood draw. So we just do a standard blood draw, we use next generation sequencing, combine this information, and we can tell you whether or not we detect a cancer signal for multiple types of cancers. So the technology exists today. This isn't a vision, it's here today. So we have a real opportunity to figure out how best to introduce it into the healthcare systems, how to educate physicians and patients to make sure you're aware of this, and then really focus in on good, proper implementation, but all based on real technology supported by lots and lots of evidence. And that's a lot of where we're investing our capital now, is partnering with great organizations around the world to help generate the proper evidence to make sure that we're able to get broader adoption of these life-saving tests.
Dave, thanks a lot. That was a fantastic answer. Thank you. I'll introduce also now Dr. Azza, who's an M42 colleague, clinical geneticist, who has a huge amount of strategic weight for us as a leader for our clinical genomics program and many other things. I'd like to just take a little break from the screening applications of liquid biopsy, which is the focus of today, and ask Dr. Azza to comment a bit on other liquid biopsy applications in the clinic for patients that have already been diagnosed with cancer. So there's a whole chapter, of course, and I think we wanted to do this just for having a more complete presentation. This two-note, a bit of an understanding or an explanation of how liquid biopsies can be deployed in the clinical oncology space. Thank you.
Thank you, Lawrence, for the introduction and for inviting me. So liquid biopsy, I'll just start by saying that 5 to 10% of tumors are inherited. So we can detect them by doing a blood analysis, germline analysis for the patient. While the majority of tumors are sporadic tumor, and sometimes even we don't know where is the primary tumor. So liquid biopsy is not only helping us in tackling what happened exactly in the somatic cells, but it helps us to identify where is the primary tumor sometimes. Also, sometimes it's not possible to take a tissue biopsy from the person, and it helps us a lot to identify what happened and what is the reason of such changes in the patient. Follow-up and the choice of the companion diagnostic, the choice of the medications that is given to the patient is essential to avoid wasting time. What we used to do before was to use the traditional therapy and then wait for 6 months to see what would be the effect of such therapy after 6 months. But of course, in most of the patients, it's too late to take another action. So diagnosing cancer by liquid biopsy is very important because it will give us insight which treatment has to be used, target therapy or precision medicine to be used. Also for detection of minimal residual disease and for follow-up of the patient who is already under treatment, whether he is responding well to the treatment or we need to shift to another molecule or we need to put adjuvant molecule to what we are using. So this is very important for the complete picture of the patient.
Thank you, Dr. Azza. We have only 3 minutes left, I'm afraid to say, and I was thinking, we have many more questions, but in order to wrap up fast, I was thinking of just asking each of our panelists to imagine that we had the magic wand, the regulators, the full perfect conditions. What would you ask, and very, very succinctly, from this magic lamp, from this genie, in order to see liquid biopsies deliver the impact that you think they can? So what would be your ask in order to see this technology reach the impact that it can? Dr. Walid, please.
Well, I certainly would like us to be able to roll this out in a thoughtful fashion to assess its impact, both on individual patients and on the population as a whole, and then use that to really help our patients. So I think it's the strategic, thoughtful use of these technologies such that we can really study the impact and then act on it.
So very diligent design of deployment and the studies linked to that. Dave?
I would say the addition of more patients using these tests will only enhance our ability to use advanced technologies to improve the effectiveness of them. And the magic wand is really, it's focused on stage 1 and stage 2 detection. It doesn't help to diagnose some cancers at stage 4. So how can we improve that? And that's the sole focus of ClearNote is really how can we detect stage 1 and stage 2. So that will improve over time, the more patients, the more samples that we get in collaboration, and we'll be optimizing that so that we can find and have much, even the highest specificity and sensitivity possible to really make a difference in saving and extending life.
Thank you, Dave. So early stage performance. Dr. Azza, what would you ask?
Also early stage performance, because it will allow us to understand what is the first hit which happened in the tumor, and so understand the pathogenesis of the tumor, how it developed and how it progressed later on.
Thank you. Martin, you've got the most difficult one because these stakeholders have already made many asks. But what would you ask?
No. I mean, we already have validated our test in 90,000 men, so we don't need that. We are already in screening by invitation programs, 2 in Europe and 1 in Asia. But what I would like to, I would love to get started here with screening by invitation, because I think it would be extremely valuable for the society.
So your ask is a deployment in Abu Dhabi, which we're kind of working on. But okay.
Very good.
Thank you. I'll have to wrap up there. It's 0000, so please put our hands together to our panels and to the accuracy of the session. Thank you so much today for being with us today. Thank you, Dr. Walid.
And thank you, Dr. Lawrence, for expertly moderating that session. May I ask our panelists, please, to pose for a photograph? We have the wonderful photographer, Father, if you wouldn't mind taking the photo. Fantastic. Thank you so much. Ladies and gentlemen, a big round of applause to our panelists. And we'll be back in a few minutes.